Welcome to the Forum at St. Bart's. I'm Peter Thompson, Associate Rector for Formation and Liturgy here. And this morning we are continuing our series on the future and turning in this time of a global pandemic to a topic which I'm sure is on everyone's mind, healthcare and the future of healthcare in this country. And we're very fortunate to be joined this morning by Professor Heidi Allen, who is an associate professor at the Columbia School of Social Work. She was a lead investigator in the Oregon Health Insurance Experiment, and she is a nationally recognized researcher, writer, and advisor in the field of health policy. Professor Allen, thanks so much for being with us.
Thank you so much for inviting me. It's really wonderful to be here, and I'm excited to hear the questions that come up, and so thank you. Should I just get started?
Sure, go ahead.
Great. So just a little bit about my background. I as a social worker, and I worked in acute mental health, a level 1 trauma center emergency department. And I spent 5 years, a really good place if you want to see the way that healthcare works and doesn't work. And I went from there to state healthcare policy and administration, working in federal policy as a fellow with the Assistant Secretary of Planning and Evaluation. And that's kind of the president's policy shop. And I teach at Columbia. I'm in a school of social work because I still really identify as a social worker and think that social work perspectives and values add a lot to health policy. And I study access to care and the Affordable Care Act. So that's who I am, and that's the perspective that I bring to this. And I thought I would start out by just talking about some of the questions that I ask myself when I'm thinking about the future of healthcare. Some of these are empirical questions. There's research to support one answer or another. Some of them are really value questions. And we're going to, to come to an answer, you really have to tap into your moral core. Like, what do you think matters? So the first question that I think is really important for us to ask ourselves when we think about moving forward is, do we think that healthcare is a human right? Is it like the fire department or education to 12th grade? Is it like our roads and bridges? Do we believe that a person should not be withheld healthcare because they are poor? And if it is a human right, who do we think should pay for the people who can't pay for themselves? And with the rising costs of healthcare over the years, that's increasingly everybody. There's very few people that would be prepared to actually pay out of pocket for a serious health condition or a health crisis. And if we are willing to pay for it, and we think it's government or the taxpayer's role to pay for it, are we willing to pay for everything? Do we think that if a treatment is effective, then that equals people should access it? Or is there some kind of basic level that we think that society should be willing to pay for, but extras people should have to pay for that themselves? So that's the first question. And we've never asked that of ourselves as a country. We have what I think of as a pretty accidental system, a system that was built up over time. It's built around categories, through employment or age or pregnancy status or disability status. And there's a lot of people left out of those categories. And all of us move between categories over time. So that means that over a lifetime, a person will have periods of time where they're employed, they'll have a period of time where they're elderly, and they will have maybe a period of time where they're unemployed, and they will kind of move. And a lot of people fall into gaps during this. The second question is, if we were to design a system, if we were to start from scratch, what kind of system do we think would be the most equitable and the most efficient? And when we look at that question, we have to think about what is going to be the role of profit. is healthcare a middle and upper class jobs program? Do we think that profit drives innovation? Do we think that profit creates perverse incentives that could lead to inefficiencies or even worsen health? Another question within that question is, do we really care about equity? Is it okay to have systems that are tiered, like the one we have now, where at the top of the pyramid is the employer-sponsored insurance, and you drop down to marketplace insurance, and then you drop down to Medicare, and then you drop down to Medicaid, and at the very bottom are people that are self-pay but can't afford to really pay. And then again, within this, like, what system will we create? What are the societal trade-offs we're willing to make for how much we spend on healthcare? Are we willing to invest less in education, assuming a finite amount of resources? Where, as technology increases, as what we can do increases, as the costs continue to increase, where do we take that money from to reallocate it towards health? And are we getting what we pay for? And how do we know? So that's question 2. And question 3 is there any way in our new system that we're thinking about moving forward, is there any way that we can leverage investments in health for long-term health benefits? Currently, we don't really have very much incentive for insurance companies to think about your health after a year. Employers switch insurance plans, people switch employers, so that relationship isn't very stable. People move in and out of public health insurance like Medicaid, and the budgets for those are made on an annual basis by people who are elected, and so may not be serving in their state legislature 5 years later. So they may not be as invested in putting more money up front for longer term health investments. Really, the only place that we are poised to see those gains is in the Medicare program. But we know that a lot of what we think of as social determinants of health are really kind of costly places we might have to invest up front. The damage is already partially done by the time you hit age 65. So that's not going to be the most efficient way for us to see a long-term investment in health. So how would we have a system that would allow us to really put money into something that maybe won't pay off for 10 years? So that's my 3 questions. And I look forward to like any thoughts that comes to your mind related to that, or Reverend Thompson, if you have any thoughts.
Great. So if you have questions or feedback to share with Professor Allen, please use the live chat function on YouTube, the comments function on Facebook, or you can email me, pthompson@stbarts.org. That's pthompson@stbarts.org. Professor Allen, I know you were involved in this very big experiment in Oregon, and I wonder if you can talk a little bit about that and what you learned and how the findings of that experiment interface with these questions and help inform them.
Sure, yeah. So true to our system, I think emblematic of our system, the state of Oregon had a Medicaid expansion program. This is before the ACA, the Affordable Care Act. And it was a voluntary expansion, and Medicaid is a program that requires both state and federal dollars. And then the state went into a significant budget crisis. And what you need to know about the Medicaid program is that it's a counter-cyclical program, which means that it's funded through state tax revenues. And when employment goes down, when people lose their jobs, they're paying less into the tax system, and yet eligibility for Medicaid goes up. So you get a draw on the public program right at the time that you have less resources to fund it. So that in itself is like a really problematic situation, and it's one that we're seeing right now with with COVID-19, because we have a lot of people who've lost their jobs, a lot of people who've lost their income. They're trying to apply for Medicaid. The state has less resources than ever before to meet that need. So the state of Oregon, which is where I was living at the time, they closed their Medicaid program to new enrollment, and they've introduced some policies that led to a rapid disenrollment of people. And over time, the program shrank to about like 13,000 people from over 100,000 people. And so they got to the point where they had enough surplus in their budget that they said, well, we should open back up in a limited way to give people access to health insurance. And but they were kind of stuck because they knew that 100,000 people had lost health insurance. And so they knew the demand was going to be much greater than the supply of how many people they could cover, which was only about 10,000 additional people. And at first they asked the federal government, can we give Medicaid based on people's need? So can we, reserve it for the people who are the sickest? And the federal government said, no, you can't. That's not ethical. How do you weigh a person that has diabetes with a person who may find out that in 2 weeks that they have cancer? So what they did is they held a lottery. They widely advertised that they were going to open up for 10,000 spots. They had people sign their name and provide their address and contact information. And then they randomly drew names out of a hat to offer those people the chance to apply for Medicaid. So this is essentially, in research, a randomized control trial, which we have never had in health insurance, except for the Rand Health Insurance Experiment, which is a famous experiment from 30 years ago. Actually, it's probably like 40 years ago now. And that wasn't even randomizing health insurance to the uninsured. That was randomizing different levels of cost sharing, like premiums and copayments. So this is the first study that's able to look at the causal impact of giving people health insurance. And so that made it in itself a pretty significant study. And this is, again, before the ACA. So we, some researchers, Kate Baker, who's now the dean at the Harris School in Chicago, Amy Finkelstein from MIT, myself, our colleague Bill Wright from Oregon, we launched a really ambitious data collection effort to try to get at as many of the outcomes that we think could happen for giving somebody who's uninsured health insurance. And the study results were, I like to say, in some ways it's like research from the center of the study of the patently obvious. If you give people health insurance, what we learned is that they use it and they use more care. So they're more likely to have a doctor. They're more likely to go to the doctor. They have more visits when they go to the doctor. They fill more prescriptions. They have more hospitalizations. And we found that those were primarily related to things like related to cardiovascular health. So, heart surgeries, things like that. We found that they were more likely to get their preventive treatments like flu shots and tests and screenings. They were also more likely to go to the emergency department, which was kind of a controversial finding because one of the arguments for expanding health insurance to the underserved has always been that will keep them out of emergency departments and that will free up resources in the emergency departments, and emergency departments are so expensive. And all of that makes perfect sense, but it doesn't take into account that while people who are uninsured are more likely to go to the emergency department for things that they could have seen a primary care doctor for, they're actually less likely to go to the emergency department in general because they have to pay for it. So when you remove that cost barrier, they're more likely to go. And so in some ways, it just depends kind of what your priors were and how you interpret that result. We did not find in the 2 years that we studied much of an impact on health outcomes. People did report their health as being more likely to be stable or improving. We saw a really dramatic reduction in clinical depression. And so those are very promising, but we didn't, and we saw increase in the diagnosis and treatment of diabetes, and we saw a change in blood sugar that's kind of where we would expect it to be based on the increase in diagnosis and treatment, but it didn't, I don't know that we had enough statistical power to detect if that was statistically significant. But we didn't see a decrease in risk factors like smoking or obesity. We didn't see a reduction of hypertension, things like that. So people have taken the results of our study, and some have argued that it is really conclusive evidence of why health insurance is important for people and why we should expand Medicaid. And there's still 13 states in the United States that haven't expanded Medicaid to low-income residents. And some take the results and use it to argue against expansion of Medicaid. They still say that Medicaid is bad insurance, and they still say, look, Medicaid doesn't improve health. Since then, there have been other studies that have been from the ACA Medicaid expansions that I think do provide a pretty conclusive argument for expanding insurance in terms of the impacts of health insurance on health. So that's our study.
Yeah, it's a really fascinating and I imagine important study in your field.
It's been a fun study. Yeah. Lots of people have lots of thoughts about it, and that's what you want from your research.
Can you talk a little bit about how COVID has affected the way people talk about health insurance, as well as the reality of health insurance, given all these new needs in terms of testing and vaccines, et cetera?
I think it is such an interesting time. So what makes it particularly interesting is you have the intersection of a pandemic with a presidential election year. So you have the rhetoric around socialized medicine and, repealing the ACA, which was such a part of the 2016 debate. And it continued to play out in the 2020 debates. At the same time, is the weaknesses of our current system have never been more evident. As the shutdown started happening around the country, people lost their jobs and they lost their health insurance. And they lost their health insurance at a time when you really need to have health insurance. So you would think that would make people step back and say, oh, this isn't a very secure system. I can't rely on this system when I'm in need. You would also think that people would step back and say, it's not just about me and whether I have health insurance, because if my neighbor doesn't go and get her COVID diagnosed and she continues to go out into my community, she could give it to me. And so we're all intertwined and we're all connected. And so we should have a system that recognizes that. We don't want anybody to not seek care because they can't afford it during a pandemic for their health and for all of our health. But that hasn't really changed the debate much. And I think that that's because the fact that we were in a presidential election year. And so even the public option, which Joe Biden is part of Joe Biden's platform, is a pretty conservative step forward. It's an incremental step forward on our system. It does give the government a chance to bring in people that don't currently have coverage. It does give the government a chance to perhaps lower healthcare costs for consumers by negotiating prices. But it's not a system that is transformative, that would really position us to be able to deal with the next pandemic in a way that, regardless of whether you have a job, you're able to keep health insurance. I mean, I think presumably the public option would be there if people became uninsured, but it's still fairly incremental. I think that one of the reasons that the Republican Party has struggled with repealing and replacing the Affordable Care Act is simply that it in itself was a very conservative piece of health policy. So it was modeled after a plan in Massachusetts championed by Mitt Romney, who's a Republican, and it has a lot of the elements of a proposal that the Heritage Foundation, which is a very conservative think tank, put forward as their counter proposal to the Clinton plan way back in the day. And the private marketplace, expansions through a private marketplace rather than government, and subsidizing that to make it affordable for people, Medicaid expansions, employer mandates, individual mandates, all of those are actually fairly conservative health policies in the context of what the rest of the world, our peer nations are doing. So the long-winded answer to your question is I don't think it's changed the debate nearly as much as it should have. I think people are really sticking to their priors on this.
Sure. So there have been several questions about comparing the American healthcare system to healthcare systems globally, and why there are such differences in how many people are covered, in the cost of healthcare to the systems, et cetera. Can you speak a little bit to that? How different countries evaluate these questions that you mentioned at the beginning?
Yeah, so a lot of countries developed their system after World War II. And they actually did take a step back and say, what kind of system do we want to have? And it varies. There's systems that are where the government is the insurer and the government is the provider. So, if you provide healthcare, you essentially work for the government. And that's a fully contained system. So all of the incentives are kind of aligned towards keeping costs down and keeping people healthy. Not that they don't struggle with costs, because every country is struggling with costs, but they don't have the equity issues that we have here in the United States, which are just simply awful. We have the best healthcare in the world for some people and then nothing for others, which is not something that other countries have. Some countries have where the government is the payer, but providers are privately employed. So there's a lot of different options, but generally what other countries, our peer nations, tend to have is an everybody in system. So it's not based on categories, even if employers still do contribute to the cost of providing health insurance, because they're the ones that often benefit from having a healthy workforce. So we think of it, like employers also pay taxes to make sure that we have roads that they can use to deliver products on. It's much the same concept. But everybody is covered from the time that they're born until they die. Another thing that our peer nations have that we don't have is explicit rationing. And we don't talk about this nearly enough. As every time a new innovation comes out in healthcare, and there are a lot of them, and there are even more in the future. Like, we can't even comprehend what we're going to be able to do a decade from now that we can't do now. They cost money. And if you are on a finite budget, you have to say, okay, are we going to pay for this? If so, who gets it and who doesn't? Because it's not an option just to kick people off to pay for it for other people. That's explicit rationing. That is a community coming together and saying, this is worth paying for, and we're going to not pay for some other things in order to make this happen. Or we're going to pay more for healthcare. We're going to raise taxes. We're going to invest more in healthcare, which means taking it from another priority that we might have. In the United States, we implicitly ration. So there's some new innovation. There's lots of new innovations. And the price of healthcare goes up, and some employers say, well, you know what, it's now just too expensive for me to offer. So employers drop the health insurance, or they pass the costs on to consumers through deductibles or co-payments or co-insurance. And sometimes that's too expensive for consumers, so they stop paying for health insurance and they become uninsured. So we ration people. We don't ration services. And we don't even really have a lot of criteria to say what's best. So is the new innovation actually better than what we had before. We test every new treatment against the placebo. And the question is, do we see a statistically different, or do we see a statistically significant improvement? Every clinical trial is different. And so it's not even where you can always compare clinical trial to clinical trial. And we don't really do that. We just basically say, if you show that this is efficacious, most insurers will pay for it. And if it's really, really expensive, then maybe some insurance won't pay for it, like Medicaid. And then that's just adding to the equity issue that we have.
There's a question about telehealth and how that is changing the healthcare field as well as healthcare policy.
Well, telehealth was obviously already a thing before the pandemic. And it's often touted as a really important solution for people that have limited access because of where they live or transportation. So I think that telehealth in any context is really critical. And I think that what we've really seen is in rural areas. Now, the other side of that is we haven't invested in rural broadband to the extent. So, sometimes it really is telehealth. Sometimes it's really by telephone because people don't have good enough internet to interact with providers. But if you live in a community that just cannot afford, doesn't have a market for some kind of specialist provider, it enables you to see that provider remotely without having to, drive for a day, rent a hotel, all of that. So it's really, really important from that perspective. And in the context of COVID-19, it's been critical. And I think that the system has been rushing to try to catch up. And the way that they've had to try to catch up is, what are they willing to pay for? Because not all insurers were willing to pay for a primary care telehealth visit for somebody living in an urban area. So they but I think that everybody really did amp up their systems. And I think that there's been a significant investment in the technologies to support telehealth since the pandemic began. And I would anticipate that we will continue to see much higher use of telehealth even after the pandemic ends, just because of the ways that we found that it's convenient for people to connect with their providers. And even just, the healthcare environment, a clinic, a hospital, they are germy places. So you don't always want patients coming in and sitting in a lobby and then going and sitting in a room. That in itself, particularly for immunocompromised patients, is a risk. So it's going to be, I think, transformational in that people have a lot more faith in it now and policymakers have a lot more faith in it now than they did prior to COVID.
Do you think insurers will continue to accommodate telehealth at the same level post-COVID?
Yes, but I think that they will raise the standards of what they expect. As they have more time to think about it. Sure. And they may put some limits on it. Though for them, I don't know that, but I think the research hasn't caught up with it. So I don't know if they're charging insurers as much as they would for an in-person visit. My guess, if I had to put money anywhere, is that they are. And it may be that there's some pushback from insurers that, that they shouldn't, because they don't have to pay for the same infrastructure that they would have to pay if the patient were coming into a clinical setting. But I think that we've all been very reactionary in this, and I don't know where the conversations will lead when everybody has a chance to step back and think about it.
Sure. So a healthcare provider asks about your thoughts about accountable care organizations, and he uses an acronym DSRIP, which I'm not.
DSRIP.
Yeah. Can you speak to those things?
Yeah. So basically, accountable care organizations is a payment reform system. So one of the the issues is that in a for-profit system, even a nonprofit for-profit system, because our nonprofits in the United States make a lot of money, the incentives are usually for providers to get paid, and people have to use your services to get paid. And so an accountable care organization is trying to get everybody who touches a patient towards an incentive of actually improving health. And if that means that it decreases the number of visits they have with you as a specialist, that you somehow are able to still reap some of the financial reward of keeping that person healthy. And they've been implemented a lot in Medicare because the federal government is the payer for Medicare. And so they're able to pilot a lot of experiments. And they've been very effective of shaping the entire healthcare landscape by the way that they've experimented. The research on accountable care organizations is pretty mixed. I think that part of what you're measured on are these quality indicators, and I think that you do see some improvement in the quality, at least on the things that people are reporting on, which, there's always the concern that there's, teaching to the test phenomenon. But I don't think that people at this point are thinking that accountable care organizations are going to really be what we need to reduce costs in the country. It doesn't make us a Kaiser system, a Kaiser Permanente system. It makes us a pseudo Kaiser. And in some ways, it increases the purchasing power of the providers because they're all kind of at the same table. And so they can push back more on insurers on how much they want to get paid. So there's just a lot of moving parts and a lot of different incentives coming with each other. DSRIP is a waiver that New York State has with the federal government to test a bunch of upstream investments in health for Medicaid. And these are intuitive things, I think, for a lot of people. For example, if somebody who is without housing comes into an emergency department and they have an infection and they need a place to rest and recover, do we pay for them to go into some kind of temporary housing situation? And will that mean that they will actually get better and not come back sicker and have a more expensive emergency department visit later on? I think in DSRIP, they've put a lot of emphasis on this idea of reducing emergency department visits. And so they're investing all these money in kind of upstream innovations, and then they're testing, do emergency department visits go down? And to me, I think that that's a very limited way of thinking whether there's an impact on people's well-being related to investments in their health. One, people go to the emergency department usually when they're scared or they're in pain, and that's always going to happen, or if they have an accident or an injury. And even if we reduced emergency department visits to zero, so like nobody's using them for anything, that's like 3-ish to 5-ish% of the healthcare dollar. So that is not also going to save our lives in terms of our financial health as a country in dealing with health insurance. And also there is the issue of all of the DSRIP activities are happening at the same time and in different environments. And it's really difficult to test the results of that in a year or 2 years or even 5 years. What would be the health impacts of giving somebody shelter or giving people temporary or even permanent housing? Would you see them in 1 year? Would you see them in 2 years? Would you see them in 10 years? Well, if somebody is acutely sick, you might see it in 1 year, but also there's what we always call regression to the mean, which is that somebody who is acutely sick one year might either die or naturally get a little less sick the next year and have their healthcare costs go down. So from a research perspective, it's really, really hard to tease out which of these interventions are worth continuing to invest in.
Can you speak a bit about prescription drug prices, and the current administration has made that somewhat of a priority? Has there been any meaningful change in that area?
So This is all fairly recent. There was talk of a rebate to lower income Medicare recipients for $200, which from my perspective would have been fairly meaningless. It's always nice to get $200. The Affordable Care Act was really important for reducing health or prescription costs for seniors by closing the donut hole, which had been part of the policy. We don't negotiate prices for Medicare Part D, which is, I think what Donald Trump is talking about trying to do now is indexing those prices to something. If you think of the government like Walmart, which it is in many ways, so Walmart brings their prices down by basically saying to companies, I'm bringing you millions of customers. And if you want people to come to me and come to you, you have to offer me a really good deal. And that is the basic principle of purchasing power. The more people you have in your group that you can say you're going to purchase for, the more power you have to bring down prices. But we haven't leveraged that in our country. And it had a lot to do with pharmaceutical lobbying when Medicare D was created and compromises that people made to even create Medicare Part D. So there was it became prohibited to do this. Now, in the limited period of time that President Trump has between now and when Joe Biden is inaugurated, will he be able to use executive authority to meaningfully address prescription drug prices? My guess is no. But is that worthwhile? Absolutely.
Can you talk a little bit about mental health and its place in the picture in terms of a society caring for the well-being of its members?
Yes. It is another interesting thing about our system that is different from peer nations is that we not only chop people up into categories, we take the body and we chop it up into categories. So we have different health insurance for dental than we have for physical health. And then we have different provider networks for mental health. And we don't really see the person holistically. Mental health access has always been an issue in the United States. It, for a long time, fell on government. So people would have to be impacted to the extent that they were involved in the criminal justice system, like they'd been arrested or they were institutionalized. Or they had money to pay out of pocket. And so we had a system kind of built around government, usually the state and city as payers, and people paying out of pocket. And then, we started offering mental health benefits, but it was not at all the equivalent of the health benefits, which is kind of like what we have for dental now. People have dental insurance, but it's not good insurance. It doesn't pay for much, doesn't get you much. And that's what we had for mental health. And we had numerous pieces of congressional legislation that tried to get what we call parity, which is that where mental health would be paid at the same extent and without limits in the same way as health was paid for. And the Affordable Care Act really put teeth behind parity. So there are provisions in the Affordable Care Act that creates a system to enforce parity. And mental health is one of the defined essential benefits for any plan that participates in the marketplace. So that's great. But the provider response, and you see this very much in New York City, I think probably more in New York City than in anywhere else in the country, has been to say, so people now have health insurance for mental health and they have benefits, but what the insurer pays is not what the provider wants to get paid. And so what you see a lot in New York City is people who do not take insurance at all. And that means that for a person to access that, they either have to pay out of pocket, which is so expensive. Who has the resources to pay $300 a week every week for who knows how long. Not very many people. And if they're lucky to have out-of-network benefits, then maybe they will get 60% of that paid for after they reach an entirely different deductible than their normal deductible. So that also is a lot of cost exposure. And so what we have now is a system that is still not equitable, and where access related to financial barriers is still incredibly problematic. And there's also research to show that what's happening in New York City is not just limited to New York City, that there's been a really big increase in people using out-of-network benefits. And not everybody even has now out-of-network benefits. So for some people, that's not even an option. And it's just extremely cost prohibitive for a lot of people. And I think that has huge implications for our physical health system, which is siloed, because people get depressed when they get sick, or they have mental health impacts of illness, and mental health can contribute to physical health. And we know that from a lot of research. So I think it's a serious problem and something that we're going to have to address.
Can you speak? There's been a lot of discussion in the public realm about Medicare for all as well as universal health care. Can you speak to both of those, the differences between the two of them, and other kind of similar proposals that have been offered?
Yeah. So universal health care and Medicare for all are fairly synonymous. It basically means that everybody has insurance. So it's not a system like you see in Canada where people have insurance and the providers work for the government. It's just simply that the government is saying everybody has insurance. And people would have that instead of their employer-sponsored insurance. So it would follow them, as they go from childhood to adulthood, as they move between jobs, if they lose their job. And so that is a benefit to something like universal health insurance or Medicare for all. It also allows the government to set prices with providers, which is to engage in that explicit rationing that we talked about, which is probably going to have to happen if we ever have an affordable system. Is we're going to have some cost containment measures. And generally that is through setting prices in other countries. It is still called socialized medicine, and people are very reactive to it. What I think we don't talk about enough in terms of what it would mean for our country, is it really would mean that people would just go into Medicare earlier. So we're all going to be on Medicare. Like if we're lucky enough to turn 65, it is already socialized medicine in our country that serves millions of people and pretty well. Efforts to change Medicare and make it more like the private marketplace have been completely unsuccessful. Republicans have tried to do this numerous times, and the advocacy against that, through the bipartisan advocacy against that, is really quite strong because people actually like it. It is an everybody in, it's the first payer, meaning that you can't come, Bill Gates' use of Medicare would be similar to my use of Medicare when I'm 65. We would have access to the first payment, or we would pay providers the same. And that is really important for addressing what I mentioned earlier, which is the tiers of coverage, which is that people with private insurance have better access than people with Medicare, and people with Medicare have better access than people with Medicaid, and people with Medicaid have better access than the uninsured. So that would be really positive. But for me as a country, I don't know why we're not asking the question if it's good enough for people who are 65 and above, who are actually at the time of their life when they're at the highest risk of having health problems and needing to interact with the healthcare system. If we think that it's good enough for them, why are we so afraid of having it for people who are younger? Like when we actually probably will not interact with the healthcare system as much. So that's one thing that I'm never sure why it's not part of the debate. Like we're all going to be on Medicare. So we're just hastening Medicare. But it does trigger in people a lot of concern, and I don't know. I don't know if what we would need to have in place. We'd obviously have to have both chambers of Congress and the presidency. And even with that, I think that there would be substantial political organizing against it, primarily from the provider community, who would rightfully say this is going to, decrease our margins, and we're going to have to lay people off.
So as we end, I wonder if you can just share any questions or tidbits we should keep in mind as we continue to contemplate the future of the healthcare landscape.
I would ask that you keep thinking about this issue of explicit versus implicit rationing. Whenever there's a new innovation, whenever something really great comes out, when we're able to have nanotechnologies built into clothing for an exoskeleton to help people with strokes recover, think about who's going to pay for that, and then what is that going to do to overall costs. And if costs go up, know that that means that people who are barely hanging in will no longer be able to hang in. So we are rationing people when we just continue to pay for everything that comes along. And what would it be like if we said, we're not going to ration people? People have, we're all in this together. We're going to ration services. So what would be equitable? Who should get what? I think we have to start, if we're ever going to be at the place that we're ready to have a system like that, we're really going to have to think about the moral implications of this explicit rationing. We're going to have to wrestle with that. And then the second thing that I didn't speak to today that we're really going to have to figure out is what to do about long-term care. So Medicare, America's health insurance for people with disabilities and the elderly does not pay for long-term care. Medicaid, America's health insurance for the poor, does, and is part of the reason why states really struggle with the Medicaid budget and why they're always looking to cut Medicaid, is that long-term care is a significant expenditure. As society is changing, are people saving enough to live in a long-term care facility and pay for it out of pocket for as long as they may live, which might be longer than in previous generations? They might live longer with more significant health morbidities. And I think that currently we don't really have any plan at all, and we're going to have to come up with some kind of plan.
Well, unfortunately, we have to leave it there. Professor Allen, thank you so much for getting up early and taking this time with us. It's been really informative and rewarding to hear from someone with so much expertise in this area. So thank you so much.
Thank you for having me. I really appreciate it. Have a good day.
Thank you all for watching. Please join us for worship at 11 a.m.